So the title of this talk is going to be the nasopharynx essential anatomy and nasopharyngeal carcinoma. So that was the topic I was given. So I do have one disclosure. I am a consultant for an artificial intelligence company. That won't be relevant in this talk because I will not be discussing anything about AI. What we're going to do is start off with nasopharyngeal anatomy. And the first thing that I really want to discuss is when I look at things like this, sometimes I have to ask myself, why in the world do we have a nasopharynx and where is the nasopharynx? So the nasopharynx is located above the level of the hard palate and the soft palate. So when we look at the craniocaudate dimension, when you swallow, your soft palate closes. So if you're eating something, it prevents it from going to the nasopharynx. And that's because when your soft palate hits the posterior pharyngeal wall, there's a ridge here called passivans ridge. So the posterior margin of the nasopharynx is going to be the posterior pharyngeal wall, and the inferior margin is approximated by the hard palate, but technically it's where passivans ridge is where your soft palate opposes the posterior pharyngeal wall, so you don't have what we call nasopharyngeal aspiration. The anterior margin is formed by this area right here, which is the posterior aspect of the nasal cavity, which are the choana. So the anterior margin of the nasopharynx is going to be the choana, and then the superior margin is going to be at the skull base, with the lateral margins being the lateral pharyngeal wall. We'll talk more about this. But I did want to emphasize about why we actually have a nasopharynx. And for me, it's always kind of been interesting. So first of all, we tend to breathe through our mouths and our noses. And if we breathe through our nose, we have to have an air-containing chamber, which allows the air to come in, then eventually make its way down the back of our throat and into our airway. So you have to have an air-containing chamber. The second thing is that the nasopharynx actually communicates with the middle ear cavity through this opening, and this opening is the eustachian tube. And so I know we've had lectures before. You can actually look at a temporal bone CT many times in a patient that has diffuse mucosal thickening and thickening of the trabecula, and you can suggest that the patient actually has chronic eustachian tube dysfunction. And if you have eustachian tube dysfunction, there is no continuous air from the nasopharynx that extends into the middle ear cavity. So our middle ear cavity would not be aerated unless it was continuous with the back of the nasopharynx. So as a result, this air-containing structure needs to be open. It needs to be very, very thick. And what keeps this open right here is this very, very thick fascial layer, which we refer to as the pharyngobasilar fascia. Now, one thing about the fascia is that ever since they were initially described back in the 1800s by Malgagny, the fascia have changed its name numerous times. In fact, Malgagny once wrote, the name of the fascia changes by the person whose pen is writing about them. So we use the term pharyngobasilar fascia to specifically describe the nasopharynx, and it's a very, very thick fascial layer that keeps the nasopharynx open. So when we talk about the nasopharynx, the radiological landmarks that we're familiar with are these little three primary structures. So this little bump right here is referred to as the torus tubarius. We have this little V-shaped opening with this opening of the eustachian tube. So when you look at the schematic illustration, this opening of the eustachian tube is
excuse me to interrupt you.
Yeah.
They do not see your pointer. Could you just make the mouse, yes, with a laser pointer?
Let's see. Yeah, sure. Let me see how to do that one. Hold on for 1 second.
So once you go into the yes, exactly. Thank you.
About that. Perfect. Thank you very much. Perfect. So this right here is a torus tubarius. Then we have the opening of the eustachian tube. And right back here is the famous fossa, and that's the fossa of Rosenmuller. And the other name for the fossa of Rosenmuller is the lateral pharyngeal recess. So this is the typical surface anatomy that you end up seeing for the nasopharynx. Now, when you're looking at the nasopharynx as well, there's more intricate anatomy. And there's a famous little defect that's located within the pharyngobasilar fascia that's called the sinus of Morgagni. And it has a couple of important implications. And first of all, it's a natural defect. So when we do talk about squamous cell carcinomas, it is felt that the initial spread of nasopharyngeal carcinoma into the deeper spaces, which we'll discuss in detail, is through the sinus of Morgagni. The sinus of Morgagni is present because it allows several structures to extend into the nasopharynx. One of those we already talked about, which was the eustachian tube. And then we have these two muscles right here. You have a muscle here and a muscle here. And these are the two Italian muscles that we learned about in medical school. The medial one is the levator veli palatini muscle, and then the lateral one is going to be the tensor veli palatini muscle. We then have two primary arterial supplies, which are the ascending palatine artery and the palatine branch of the ascending pharyngeal artery. So the applied anatomy that we always have to remember is this area of the sinus of Morgagni, and this is why we have this, which allows these specific structures to provide function to the nasopharynx. So when we talk about nasopharyngeal carcinoma, it is endemic in certain parts of the world. So there are various etiological factors. As I mentioned before, part of it is endemic, and it's felt to be more prominent in Southeast Asia, the Middle East, and North Africa. And in large part, it's due to Epstein-Barr virus. So in the new 8th edition and the 9th edition, the strong association of EBV and nasopharyngeal carcinoma has been clearly identified. So this is an example of patients that have Epstein-Barr virus-associated nasopharyngeal carcinoma, and this looks at the global instance of nasopharyngeal carcinoma. And we can see the darker color orange right here indicates these endemic areas of nasopharyngeal carcinoma. And you can see they pretty well map out to the overall incidence of nasopharyngeal carcinoma worldwide. Now, there are other etiological factors that have been associated with nasopharyngeal carcinoma. We can have early exposure to Cantonese fish. Some people feel it's a toxic effect due to the nitrosamines. It has been associated with smoking, it's been associated with alcohol, and there have been various genetic predispositions. So like in any type of carcinomas that involve the head and neck, oftentimes it's multifactorial. So when we look at the histology, there are different types of histology of nasopharyngeal carcinoma. There's a WHO type 1, which is the keratinizing squamous cell carcinoma, which is non-endemic, which we primarily see in the United States. Now, there's a WHO type 2, which is a non-keratinizing type. And when you look at the non-keratinizing type, there's a differentiated and an undifferentiated. Now, when we look at the Epstein-Barr associated nasopharyngeal carcinomas, the most common histologic finding tends to be the undifferentiated non-keratinizing WHO type 2. So this is the majority that you'll end up seeing globally. And there's a very rare type that's the basaloid squamous cell carcinoma, which is a type 3. At least my discussion with the pathologist says that these are pretty rare. But the most common type, as I mentioned, is going to be the WHO type 3, which is non-keratinizing. And this is the one that has a strong association with Epstein-Barr virus. Now, the association between Epstein-Barr virus and nasopharyngeal carcinoma is incredibly important. Now, if you do have a patient that comes in that has metastatic lymph nodes and there's no primary, based on the AJCC recommendations, which we follow in the United States, when you biopsy these lymph nodes, you should always send these lymph nodes for specific molecular testing. So if you sent this lymph node and you could not find the primary site and it's HPV positive or P16 positive, as Dr. Becker eloquently stated in her lecture, you assume that this is from oropharyngeal squamous cell carcinoma. But if you send it for Epstein-Barr virus and it's EBV positive, the AJCC recommendations, both in the 8th and the recently induced 9th editions, you assume that it's nasopharyngeal carcinoma. And if it's neither, if it's HPV negative, P16 negative, or EBV negative, then you assume it's a classic unknown primary. So the bottom line is that even if you have an unknown primary, test the lymph nodes. If it comes back EBV positive, because of that strong association, we presume that it's nasopharyngeal carcinoma. So how do these nasopharyngeal cancers typically present? Well, they usually present with a neck mass, and we'll talk about this a little bit later, and this neck mass is typically due to metastatic adenopathy, and we'll talk about the staging in just a little while. It can also be due to trismus. And the trismus is typically due to when you have a nasopharyngeal carcinoma here arising in the fossa of Rosemuller, it can extend laterally through the sinus of Morgagni. And if it continues to extend, it can actually involve the muscles of mastication. And we'll show this a little bit later when we talk about staging. NPC can also originate with otitis media. And again, we attributed this to the eustachian tube because in this case, this is a nasopharyngeal carcinoma that's displacing the torus tubarius anteriorly, and now it's occluding the eustachian tube. If it includes the eustachian tube, this is going to result in unilateral mucosal thickening involving the right mastoid air cells. And if this patient becomes infected and it's long-standing, you can develop the otitis media. And because these squamous cell carcinomas involve the nasopharynx, the nasopharyngeal cancer can extend into the skull base. These patients oftentimes present with cranial nerve palsies. So it's basically because of the metastatic disease and this localized spread patterns is why these patients present how they do. Now, I'm going to spend the second half of the lecture component talking about the spread pattern of nasopharyngeal carcinoma, and I'm going to relate that to the staging. And the reason why I say this is that I always say when I give this talk to the radiation oncologist and the radiologist, this is really our disease. So one of the things that I do is in Wednesday afternoon, so in a few hours after this is over, I actually go to the ENT clinic. We examine the patients and we also are there for the endoscopies. And I can tell you the most challenging cancer that we try to identify and stage are nasopharyngeal carcinomas. Because unlike with us, where we can clearly see the fossa of Rosemuller, this fossa of Rosemuller is really hard to see, especially for early stage carcinomas with direct endoscopy. So as a result, the initial diagnosis is still made by endoscopy or nasopharyngoscopy, but this deep spread is clearly up to us. So the 9th edition of the AJCC was just released a few months ago, and I've updated this talk to include this. So radiologically or staging-wise, a T1 lesion is tumor that's confined to the nasopharynx or the oropharynx without any parapharyngeal space extension. So essentially, it's in this space right here. And again, there are lots of names for the spaces. I call it the visceral space. Some people call it the pharyngomucosal space. But the bottom line is it's delimited laterally by that pharyngobasilar fascia. So a T1 lesion is purely confined to the nasopharynx, the oropharynx, without any parapharyngeal space extension. Now, one of the nuances or the new additions to the second staging is for the new staging is a little bit more clarification. So if you have a nasopharyngeal carcinoma that extends into the nasal cavity without parapharyngeal extension, this is still now considered a T1 lesion. In the past, that's been a little bit confusing to some folks. So if in the visceral space, it involves the nasopharynx or the oropharynx or the nasal cavity, this is still considered a T1 lesion. Now, if you have a tumor that extends through the pharyngobasilar fascia and extends into the parapharyngeal space and can involve either the medial margins of the pterygoid muscles or involves the prevertebral muscles, this is still considered a T2 lesion. So this is an example of a nasopharyngeal carcinoma that's extended laterally through the pharyngobasilar fascia. It's involving the parapharyngeal space, but notice how it's abutting the medial margin of, in this case, the lateral pterygoid muscle, but it's not involving it. So this has changed over time. Back in the 5th and 6th editions, I've been on the staging committee since the 5th edition. For a while there, some people would interpret just abutment of the pterygoid muscle as upstaging, but in the 8th edition, we clarified it and said that if this tumor abuts the medial margin of the lateral pterygoid muscle, this is still considered a T2 lesion. Now, a T3 lesion is this type of superior spread. So when we look at the applied anatomy of the nasopharynx, this is the area of the torus tubarius, and notice how the fossa of Rosemuller is located just below the skull base. So just below the skull base is this fissure, and this is the petroclival fissure. So what ends up happening with these nasopharyngeal carcinomas is that they can grow superiorly and they can erode the bone in various patterns. You can have direct erosion of the clivus, or these tumors can extend superiorly through this petroclival fissure and extend into the skull base. So this is an example of a nasopharyngeal carcinoma that's eroding the skull base. And if you look at the left side, here's a normal petroclival fissure that eventually becomes a foramen that looks like it's been lacerated, it's been cut, and that's foramen lacerum. But in this case, we can see it has extended into the petroclival fissure. So this would be considered a T3 lesion. And when we look at an MR, what we see here is abnormal signal involving the MR. Now, a couple of points for this is that it's impossible for the ENT surgeons to know that you have this invasion, and everybody has headaches. So for us, if we see this extension into the skull base, clinically, this is usually cult, and all of a sudden we've upstages the lesions to a T3. Now, when we start looking at marrow involvement, we know that MR is more sensitive than CT to look for marrow involvement. Now, these tumors have a very, very robust inflammatory response. So if I draw a line down the middle, compare the left side to the right side, on the left side, notice we have increased signal here. This is the normal fat in the marrow. But when we have this replaced signal, we're not 100% sure whether this is tumoral invasion or this robust peritumoral inflammation that extends into the clivus. Nevertheless, when I do my contouring with my radiation oncologist and I mention that this clivus is replaced, this area still has to be included in the gross tumor volume. Now, why is that important? And I know globally, because this is a global conference, we have to understand that not every place in the world has the same resources that we do at the major academic centers. So the bottom line is that when we are doing our contouring, at most places we are contouring with CT, but it's really better to contour with MR. Because in this particular case, if I was doing my GTV volume and I'm contouring the primary tumor here, this is what I'm going to contour. But when I look at the non-contrast T1 weighted image, which I find the best to specifically look for marrow invasion, notice how in this tumor, this had completely eroded the clivus, which we cannot see on the CT scan. So if we limited to just this gross tumor volume, we would be missing all of this tumor posteriorly. So if you are at a place that has the option of doing MR for your gross tumor volume, please try to include this, because if not, you do run the risk of actually actually having geographic misses, because CT can underestimate the full extent of nasopharyngeal carcinomas. So when we talk about T4 lesion, again, there are various radiological criteria that tell us that we can upstage these lesions to a T4. And again, why is that important? Because T1 lesions are typically treated with radiation therapy alone. T2s, it can be debatable whether you give chemotherapy, but certainly for T3 and T4 lesions, at least at our institutions, these are combined treatment with radiation and chemotherapy. So if we have a nasopharyngeal carcinoma, such as seen here, that extends into the orbit, so this tumor had extended superiorly, extending into the orbital apex, and now when we look at the inferior portion of the orbit, it's actually growing antegrade along V2. This is orbital involvement, and this would upstage these lesions to a T4. Another example of criteria for T4 lesion is if you have a tumor such as this is a nasopharyngeal carcinoma. Now, what I want you to do is draw a line down the middle and compare the right side to the left side. The white arrow here points at an oval structure, and this oval structure is just medial to the pterygoid muscle. This oval structure represents V3. So if I draw a line down the middle, we can see the normal fascial planes on the left, but on the right-hand side, notice how this tumor is abutting the medial margin of the lateral pterygoid muscle. As a result, this is now involving V3, and these tumors can jump along V3 and grow superiorly into foraminal valley. So here's the same patient, nasopharyngeal carcinoma growing through the pharyngobasilar fascia, jumping on V3 and extending through foraminal valley all the way into the region of the cavernous sinus. So this is a criteria for upstaging to T4. And again, most of this type of spread is asymptomatic. By this time, when it's this early, the patients typically don't have trismus or V3 involvement just by this type of spread. Another criteria for T4 lesion is when you have intracranial extension. So what can happen is that you can have these nasopharyngeal carcinomas extend superiorly through the skull base, through the foramen lacerum, and right here is the carotid artery. These tumors can then grow along the carotid artery all the way into the central skull base. And in this case, we have tumor involved in the cavernous sinus. Here's a normal appearance of Meckel's cave on the left. And here we have complete involvement of Meckel's cave. And in fact, if I draw a line in the middle, compare the left side to the right side, here's normal's Meckel's cave. This little enhancement right here is a small little vascular plexus. The trigeminal ganglion is going to be just below it. And here we can see this tumor growing up to involve Meckel's cave and extending all the way into that central skull base. So again, this is an example of radiological evidence of a T4 squamous cell carcinoma. Now, when we talk about lymph node staging, again, in the 9th edition, and this was in the 8th edition as well, we do have a different staging criteria for nasopharyngeal carcinomas compared to what we just heard for oropharynx and oral cavity cancers. And the AJCC made it a little bit more simple. So if you have unilateral cervical adenopathy that's less than 6 centimeters above the cricoid cartilage or a metastatic lymph node, as Dr. Becker showed in her last lecture, this is considered an N1 lesion. But on the other hand, if you have bilateral cervical lymph nodes that are less than 6 centimeters, this is N2. And the way that I remember N1 and N2 is N1 means one side of the neck and N2 means two sides of the neck. So I know sometimes the neck staging can get a little bit confusing, but these are some little tricks and mnemonics that I use when I'm in my clinic and we're staging these NPCs. Now, the N3 disease are going to be cervical lymph nodes that are greater than 6 centimeters or lymph nodes that are below the cricoid cartilage. Now, in the old days, we used to say that there were lymph nodes involving the level 4 and the supraclavicular lymph nodes, but it was really hard to separate out the bottom part of 5, the bottom part of 4, and the supraclavicular nodes. So what the AJCC did in the 8th edition is that any nodal disease below the cricoid cartilage is considered N3 disease, and it's really made life a lot easier for us. Now, in the new edition, in the 9th edition, they did add the concept of advanced extranodal extension. Previously, extranodal extension has been in the 8th edition for oral cavity cancers, but realize that that was supposed to be correlated with the clinical findings. In the 9th edition for AJCC, for nasopharyngeal carcinomas, you can have isolated radiological findings, but it has to be obvious extranodal extension. And again, this was just released a few months ago, and the examples that Dr. Becker showed in her lecture were good examples of classic advanced extranodal extension. So this is the new staging system for nasopharyngeal carcinoma. So that's my regular talk, and now I have about 17 minutes left, and I'm going to go ahead and start with the various interactive cases. So hopefully I can get this thing to work. And this is the first question that I have for my polls. So this is a 55-year-old male with proven nasopharyngeal carcinoma. So what I want you to do is identify what is the tumor stage. So we spent a lot of time going through this tumor staging. So what I'd like you to do is tell me what stage do you think this tumor is. Is it T1, T2, T3, or T4? Okay. Give it a couple more minutes. I would encourage you all to respond because I think a lot of what we do in head and neck, and especially these talks, really is interactive. I remember in the old days where you would go to a lecture and the content was gone. Now it's so great because there's so much content that can be accessed. And trying to commit yourself to something like this, I think is really important. And again, we're all friends right here. I don't know who's answering what, but we're all friends right here. So please, I encourage you to answer all these questions. So this is great. So what we end up having right now is uh, what we have right now is we have the majority of people got this correct. 71% said it was T2, and that's correct. So what we have here is a tumor involving the nasopharynx. It's extending through the pharyngobasilar fascia and it is extending into the parapharyngeal space. We can also see a little bit of involvement here involving the parapharyngeal space, and there's that involvement of the prevertebral musculature. So because this is involving the parapharyngeal space and it's not extending laterally, a T4 lesion would have to involve the masseter muscle, and to involve the lateral aspect of the masseter muscle. This is not a T4 lesion, rather, this is a T2 lesion. So very good for that. So now let's go on to this one. We've spent a lot of time talking about nasopharyngeal carcinoma. What about this case? This is a patient, a 60-year-old male that presents with diplopia. What's the most likely diagnosis? So this is a T2 weighted image. This is a T2 weighted image in the axial plane, and this is a T1 weighted image with fat suppression and with contrast. So this is a contrast enhanced T1 weighted image. The plus means right here with contrast. So what is the most likely diagnosis? Is this an encephalocele? Is it a chordoma? Is it a rhabdomyosarcoma? Or is this a nasopharyngeal carcinoma? We're doing pretty good. I got 16 people respond. Okay, we're up to 20. We can do it. Okay, so we have about 85% of the people saying chordoma, about 7% rhabdomyosarcoma, 6%, 9% nasopharyngeal carcinoma, 6%, we keep jumping back and forth. So rhabdo and nasopharyngeal are pretty close. And then we have cephaloceles. So this actually, the correct answer is that this is a chordoma. So remember, chordomas are malignant tumors that arise from the notochord remnants. And remember, for me, I would always get this confused. The notochord does not form the spinal cord, but rather the notochord forms the vertebral body. And as a result, chordomas can arise from the polar ends of the spine. So they can arise here at the skull base, or they can arise all the way at the inferior portion of the sacrum. So those are the two most common areas where chordomas can arise. Now, the reason why chordomas have this high T2 signal, so on first glance, you can say, hey, does this look like an encephalocele extending into the nasopharynx? But realize when we give the T1 weighted image with contrast and fat suppression, this is a solidly enhancing mass. And the reason that these chordomas have increased T2 signal is that they have these little cells that are referred to as fossiliferous cells. And it took me about 30 years to say that right. I think it's fossiliferous. And these fossiliferous cells contain vacuoles, mucin, and glycogen. Pathologists describe them as very bubbly, and as a result, they have increased T2 signal, but they also enhance with contrast. So sometimes this is what's referred to as a pseudocystic appearance of a chordoma. So here's the third one. This is a 56-year-old male with headaches. So what is the most likely diagnosis? So in a 56-year-old, is the most likely diagnosis going to be rhabdomyosarcoma? Is it going to be chordoma? Is it going to be metastases? Or is it going to be lymphoma? So what do you think the most likely diagnosis is going to be in a 56-year-old, given these options? Okay. We got about 19. Come on, we can do it. We can get up to 40. I know you can do it. Don't be shy. I can't see who you are anyway. All right, excellent. Well, the majority of you all got this correct, and the most likely diagnosis is lymphoma. And so, where I'm going with this is that the most common malignancy to involve the nasopharynx is going to be squamous cell carcinoma. So, there's no doubt about that. It's going to be nasopharyngeal carcinoma. But the second most common tumor to involve the nasopharynx is lymphoma. And the reason why that's the case, as Dr. Becker pointed out earlier, is that you have this ring of lymphoid tissue. And this lymphoid tissue was named after this German anatomist who was Waldeyer Hart. So this is what we refer to as Waldeyer's ring. So this adenoidal tissue located at the base of the tongue is what we refer to as the lingual tonsils. These are the palatine tonsils that were elegantly described in the last lecture. And then we have this ring of adenoidal tissue or lymphoid tissue that involves the nasopharynx. So as a result, there is a propensity for lymphoma to involve the nasopharynx. Now, when you look at something like this, the most common tumor again is going to be squamous cell carcinoma or nasopharyngeal carcinoma. But the challenge is that what are some findings that can tip us off that can say, hey, this is lymphoma versus nasopharyngeal carcinoma? So this is one of the things that I've learned in my experience. This was a case that I saw years ago. It's when I was at University of Michigan. It was the middle of the night. I had just come in to do an angiogram in the middle of the night. It was delayed, and I decided to read some films at 2 in the morning. And so why I did that, I'm not 100% sure. But anyway, I picked up this case, and this was a non-contrast T1 study in a patient that was about 55 years old. So what I did is I did see this mass right here, and we know that the most common tumor involving the head and neck is going to be squamous cell carcinoma. So my initial urge was to say that this was squamous cell, but then something looked a little strange right here. So when I'm looking at the clivus, we know that as you get older, there should be more deposition of the yellow marrow in your fat. So therefore, this should be increased T1 signal. But instead, we can see that there's diffuse replacement of the marrow signal involving the clivus. So when I see something like this and I have a nasopharyngeal mass and now I'm looking at complete replacement of the signal in the clivus, that makes me think that I'm dealing with a lymphoproliferative or a hematopoietic process. So if I see something like this, I kind of pivot. I say, I don't think I would put squamous cell at the top, but rather I think that this is likely a lymphoproliferative process. In this case, this turned out to be lymphoma. So that's one of the things that I try to help differentiate. Another example here, this was a patient that also had a large nasopharyngeal mass. And yes, we know that squamous cell carcinomas can have extensive adenopathy. But when I see something that looks like cannonballs in the neck with very, very bulky adenopathy, and notice these lymph nodes are really, really big and the margins are very, very crisp around these, again, this makes me think that I'm dealing with lymphoma as opposed to metastatic nasopharyngeal carcinoma. So when I'm trying to differentiate between these different tumor types, this is one little thing that I've learned over the last 30 years or so that allows me to accurately differentiate lymphoma from nasopharyngeal carcinoma. So this is the next case. This is a 65-year-old male with headaches. Now, this patient presents with right serous otitis media, but the biopsy was positive for squamous cell carcinoma, which was HPV positive and Epstein-Barr negative. So a patient that presents with headaches, right serous otitis media, because we can see the mucosal thickening. And what we see here is an abnormality involving the right side of the nasopharynx. And here we can see diffuse thickening involving the torus tubarius. And we can see obliteration here of the right eustachian tube. So if it's HPV positive and EBV negative, what do we think is the most likely diagnosis? Is it nasopharyngeal carcinoma? Is it superior spread of an oropharynx cancer? Is it adenoid cystic carcinoma or is it lymphoma? Okay. So happy. Lots of you are responding right now. This is fabulous. All right. So I think the majority of you got this right, and this is superior spread of oropharyngeal carcinoma. Remember the strong associate of Epstein-Barr virus and NPC, and in fact, in the eighth and the ninth edition, we definitively link EBV with NPC. So the bottom line is sometimes, especially if you're dealing in areas that don't have as much healthcare resources, you can see these large lesions involving oropharynx and the nasopharynx. And part of it is how can we differentiate these two? So if you do your molecular testing and it's HPV positive, this suggests that the tumor is actually arising in the oropharynx and not the nasopharynx. So in this case, this was an example of a right-sided tonsillar carcinoma that spread superiorly above the soft palate. It extended into the nasopharynx, and this is why we have this involvement of the nasopharynx as is seen here. So, as I mentioned before, in general, you can pretty much identify the primary site, whether it's in the nasopharynx or whether it's in the oropharynx. But on the other hand, if you have these lesions that involve both the oropharynx and the nasopharynx, this is where I found these molecular markers to be incredibly helpful. So I would encourage you to always test for HPV and EBV as we do at our institution. So here's a next case. This is a 40-year-old female with left-sided otalgia. What's the most likely diagnosis? So what we have here is a mass involving the left side of the nasopharynx. This is a T1 weighted image with fat suppression with contrast, and we see a mass right here. And this is a T1 weighted image with contrast with fat suppression. And you can see where it's located. It's located up here into the cavernous sinus. So what is the most likely diagnosis? Is it normal adenoidal tissue, chondrosarcoma, metastases, or minor salivary gland tumor? Okay. So this one we have a bit of a mixed response. The most common options are chondrosarcoma and malignant minor salivary gland tumor. So in this case, it was malignant minor salivary gland tumor. Now, chondrosarcomas can arise here, but if we would have a chondrosarcoma, I would expect to see some type of bony involvement or rings and circles. Rather, this is a soft tissue mass. And the thing that's most strikingly about this is that we do have a mass that is demonstrating perineural spread. So if we look at the right side, here's the lateral pterygoid muscle. This is V3. And notice how this tumor is extending into the cavernous sinus. So in my experience, if I see a tumor that's involving the nasopharynx and has a lot of perineural spread with relatively little bulk, then I start thinking about a malignant minor salivary gland tumor. So this was a tumor that extended laterally into V3. It grew up along V3. It grew up along V3 through foraminal valley and extended into Meckel's cave. So the most common types of malignant minor salivary gland tumors are going to be adenoid cystic carcinoma and mucoepidermoid carcinoma. This turned out to be adenoid cystic carcinoma, and this was an example of perineural spread. Now, I do want to point out that perineural tumor spread is not the same as perineural invasion. Perineural tumor spread is what we see here. This is tumor growing along the nerve. If you work closely with your pathologist, they do specifically evaluate for perineural invasion. Again, this is a histologic diagnosis, whereas perineural tumor spread is a macroscopic diagnosis. And then this is the last case that we'll show. If that's all I have time for, I believe. This is a 10-year-old girl that presents with nasal stuffiness. So what's the most likely diagnosis here? Is it adenoidal hypertrophy? Is it nasopharyngeal carcinoma? Is it rhabdomyosarcoma, or is it lymphoma? So 10-year-old girl that presents with nasal stuffiness. Perfect. And the correct answer here is going to be adenoidal hypertrophy. And what I want to do in this last slide is just kind of talk about what Dr. Becker mentioned. I didn't know she was going to mention stripes, but anyone that's trained with me knows about my tiger stripes. So when I'm looking at lesions involving the head and neck, in general, the head and neck tends to be symmetric, not all the time, but it's incredibly important in the nasopharynx. So yes, you can have these little striations or these tiger stripes that are involving normal adenoidal hypertrophy. But what I would like to get you to do is that when you're looking at the nasopharynx, whoops, that's my marker going off there. When you are looking at the nasopharynx, remember we have this pharyngeal-basilar fascia, and we have this normal defect right here, which is the sinus of Morgagni. So in a lesion that's confined here to the nasopharynx, in a child, am more inclined to call this benign because it is confined to the pharyngeal-basilar fascia. When I look laterally, I see these symmetric stripes. I see a black stripe, a white stripe, a black stripe, a white stripe, a black stripe. And the same thing on the opposite side. So when I see these symmetries of these various muscles and fat, this is what tells me that I'm dealing with a benign process. So this is an example of a patient that has nasopharyngeal, just adenoidal hypertrophy. And what I look for is I look for that deep extension. And this is just a companion case. This was an example of a patient that has, again, adenoidal hypertrophy here. But if you look at the left-hand side, what we see here is this mass. And notice how my tiger stripes right here are obliterated. Notice the nice normal stripes on the right-hand side. But here we can see this mass, and it's obliterating those tiger stripes. So this was an example of rhabdomyosarcoma, and the way we can tell that is now we can see a focal mass right here, and we can see this extending out laterally through the expected location of the pharyngeal-basilar fascia. So I'll go ahead and stop there. My time is up. Thank you very much for the opportunity, and I'll turn it over to Dr. Beal and Dr. Becker.